Welcome to Decoding DX. We're a group of fourth-year medical students with a passion for education and patient care.
This episode of Decoding DX is for educational purposes only and should not be used as medical advice. Please consult your healthcare provider for any medical needs.
The opinions expressed represents those of the participants and are not of our affiliated institutions.
Thank you for joining us on Decoding DX. We keep learning so much through this experience, and we're so glad that you're learning alongside with us. Now, let's get to the episode. Welcome to Decoding DX. Today we are finally following up on the electrolytes video with a video on hyponatremia. So to start off, credit made clear. My biggest source and inspiration for this presentation was the amazing book called The Fluid, Electrolyte, and Acid-Base Companion by Dr. Sarah Fauble and Dr. Joel Toft. This is an amazing book. I highly recommend it for anyone in medicine. It takes the complicated topic of nephrology and boils it down into a very understandable book with really great images. A lot of my images also came from this book. So, also as a disclaimer, this point forward, we are talking about non-acute hyponatremia. If your patient is seizing or acutely altered, please call a rapid or whatever the immediate response call is in your hospital. Get them to the ICU and get them emergency treatment. This presentation is about non-acute hyponatremia. So, to start to understand hyponatremia, you can think of it kind of like fever in the sense that, in general, in and of itself, it's not harmful in most cases, but it's often indicative of something that is harmful going on. So in the case of a fever, elevated body temperature, in and of itself, that's not actually harmful. There are cases of like malignant hyperthermia where it is, but in most cases, it's not going to hurt the patient. But it does tell us of something that can hurt the patient, which is like an underlying infection or other inflammatory process going on. Similarly, hyponatremia, the low plasma sodium, in and of itself, is not going to hurt the patient. However, it indicates hypoosmolality or low osmolality in the blood, which will hurt the patient. So, the first step when you find hyponatremia in your patient is to measure the plasma osmolality. The normal is 285 to 295. So if the osmolality is high, likely there's actually severe hyperglycemia or mannitol administration going on. Most commonly, we'll see this in DKA. This happens because the high sugar actually pulls water into the plasma and dilutes the sodium that's there. And so it is a true hyponatremia, but the osmolality is not low, which again is what we talked about as being the true problem. In this case, you can correct the sodium by remembering the mnemonic sweet 16. Where you correct the sodium for the hyperglycemia by adding 1.6 for every 100 above 100 that your sugar value is. As you correct that sugar value, the sodium should correct as well. Next option is that the osmolality is normal. In this case, it's a lab error. The reason that this happens is normally because there's high protein or high lipids in the blood. And the way that the lab reports the plasma sodium is as sodium over plasma water, as you can see in this part of the picture. But what it actually measures is sodium over plasma volume, which is the entire part of the plasma, including the protein or the lipids. And so when those are excessively elevated, it causes a false number. But if your osmolality is low, that is true hyponatremia, and that is what we will be talking about for the rest of this presentation. So, hyponatremia in and of itself is excess water relative to sodium. In reality, this is a water problem more than it is a sodium problem. So you can have three different volume states in your patient with hyponatremia: hypovolemic, euvolemic, or hypervolemic. Starting off with hypovolemic, this means that you've lost both water and sodium, but you've lost more sodium relative to the water that you've lost. This can commonly happen from any sort of fluid loss from the body. So diuretics or other renal wasting of fluid, any sort of GI loss if your patient is nauseous, if they're vomiting, if they've got profuse diarrhea, if they are an acutely burned patient, or if they've just been highly febrile for a long time, that can cause insensible water losses. Euvolemic hyponatremia, you've just gained water. Typically, the sodium hasn't particularly changed, but you've gained more water without gaining sodium with it. So we commonly think of SIADH in this picture, but you can also see hypothyroidism, adrenal insufficiency, or just if someone isn't taking in enough salt, or if they're taking in too much water, such as in someone who drinks a whole lot of beer without eating other things, or the common tea and toast diet that we sometimes see with our elderly patients. Finally, the hypervolemic hyponatremia, you've gained both sodium and water, but more water compared to the sodium. So this is classically seen in congestive heart failure, end-stage liver disease, nephrotic syndrome, and end-stage chronic kidney disease. As a side note, we can't talk about hyponatremia without talking about ADH and the way that it works at the nephron. So throwback to nephrology, we know that the loop of Henle creates a very concentrated medullary interstitium in the kidney. And so when your body senses that, hey, we need to reabsorb more water, that really strong concentration gradient is there, and it allows for ADH to go over and essentially unlock the collecting duct over on the far side of the nephron. When it unlocks that, it inserts aquaporins and allows the water to flow out from the filtrate into the interstitium, into that high concentration gradient. And the amount of ADH can fine tune how much of that water is able to go in. So with absolutely no active ADH, the filtrate will be approximately 30 to 50 millimoles per liter in osmolality. But with maximal ADH, it can get up to 1,200 to 1,400 millimoles per liter. So extremely concentrated, all the way down to extremely dilute. And just for your information, over on the side on the left, we have the urine specific gravity correlated to approximate urine osmolality. I included this because it's helpful to see when, on normal urinalysis, you're given the specific gravity. But in a lot of our calculations and our academic sources, we talk about urine osmolality, which you can order on the urine and get the number. But with just a plain old UA, sometimes it's helpful to be able to convert really quickly between the specific gravity and what that approximately means for your osmolality. So we're left with these two extremes, no effective ADH or maximal effective ADH. Essentially, in pathology terms, this is diabetes insipidus versus SIADH. Now, what does this mean? A person's daily urine volume is equal to the daily solute load over the urine concentration. What does that mean? The daily solute load is how much of the solute the body needs to excrete through the kidneys. So how much the kidney needs to get rid of as waste product. And then the urine concentration is how concentrated we're able to make it in osmolality. And ADH has a lot to do with that. So in the effective diabetes insipidus, if we have no effective ADH functioning, you can see I did the math out here for you, and that'll create 12 to 20 liters of urine. And so in that case, if you don't drink enough fluid to replace that, you will get hyponatremic. On the opposite side, with maximal ADH effective, you can get up to 1,200 to 1,400 millimoles per liter, as we talked about, and that will get down to about 0.5 liters of urine output for that day. That's only half a liter. So that means if you drink more than half a liter of fluid, you'll get hyponatremic. So it makes sense then, if we have patients with extreme levels of ADH, like an SIADH, it doesn't take very much to send them over to the edge into pretty significant hyponatremia. So what's the treatment? If we have an imbalance of water and sodium, what we need to do is figure out what's causing it, address that cause, and fix the balance. So to start off, hypovolemic hyponatremia. As we talked about, this is some sort of fluid loss from the body. There are some cases when you can actually get hypernatremic from losing too much fluid. In these cases, it means that you've lost more water than you have sodium, and you haven't replaced that with pure water ingestion. In these cases, there often isn't a ton of ADH release, and that can give you hypernatremia. On the other hand, if you have sufficient volume loss to cause ADH release, and this is modulated by the hypothalamus and how it controls how much ADH is released, if you lose enough fluid for your blood pressure to go down by 10 to 15 millimeters of mercury, you will release a decent amount of ADH. And then especially if you intake fluid to try and replace that, if you intake water, it'll compound the situation and it'll lead to a hypovolemic hyponatremia. In these cases, the treatment's pretty simple. You need to figure out what's going on, fix the cause, and replace whatever fluid has been lost. So over on the table on the side, I have some of the common electrolyte values for the most common different fluids that we can lose from our body. So this can help guide you on what type of fluid replacement your patient needs. If you need more instruction on what the electrolyte contents of IV fluids are, please see our IV fluid crystalloid episode that we made last week. But this table can help you just kind of triage what would be the best way to replace the fluids that your patient is losing, in addition to whatever maintenance fluids they may need. Next up is euvolemic hyponatremia. The first step in this is to rule out other causes. So a TSH always has to be ordered. Figure out if your patient is hypothyroid or not, because that is a whole different ballgame. Also, some mild adrenal insufficiency. So we're not talking adrenal crisis here, but non-crisis adrenal insufficiency can lead to a euvolemic hyponatremia because of the pathophys of that disease. Also, just low sodium intake. We talked about the tea and toast diet earlier. So patients that just don't take in a whole lot of salt, you can get euvolemic hyponatremia because your kidneys can only reabsorb so much sodium before some of it has to be lost. And over time, that'll build up and you won't have enough sodium in the body. Thiazide diuretics are also very well known for doing this. They oftentimes don't cause enough fluid loss for the patient to be clinically hypovolemic, but they do cause enough sodium loss to cause hyponatremia. But if all of those are ruled out, what are we left with? We are left with SIADH, or syndrome of inappropriate ADH. The four main characteristics of this syndrome are hypotonic hyponatremia, which is what we've been talking about, euvolemia, so on volume status exam, they're euvolemic. Their urine sodium is greater than 20 milliequivalents per liter, and their urine osmolality is more than 200 millimoles per liter above the plasma osmolality. If you think about this, this indicates a pathology because that's inappropriate in the case of hyponatremia. If a patient's blood is hyponatremic, their kidneys should be reabsorbing as much sodium as they can to try and fix that. And these urine tests don't look like that. It looks like the kidneys are wasting the urine and concentrating it too much when we should be reabsorbing that sodium. So that tells us that there's inappropriate amounts of ADH going on in the setting of a hyponatremia. And oftentimes the question is asked, how is it euvolemic if ADH is causing us to reabsorb all this water? The answer is that the other mechanisms of the kidney for regulating volume status are still intact. So with the ADH causing excess fluid to be in the body, that turns off the renin-angiotensin-aldosterone system, which means that other sodium reabsorption pathways and water reabsorption pathways in the kidney are turned off. So that keeps the patient in a euvolemic status and keeps the sodium wasting continuing through the kidney. Common causes of SIADH, I'm not going to run through all of these, but one thing to note is that just simple stress and pain and even nausea can cause SIADH in our patients. So this is actually a pretty commonly seen thing in the hospital. So that's not something that you can just attribute hyponatremia to. You always need to work up hyponatremia. But if you rule out the other causes, this is a reasonable explanation for a mild hyponatremia in a hospitalized patient. And in the end, the treatment of SIADH is fluid restriction and addressing the underlying cause. Finally, we get to hypervolemic hyponatremia. This is a pretty intimidating slide, so we're going to take it in chunks. Starting off, we have decompensated congestive heart failure. With CHF exacerbation, we get fluid back up into the venous system, which causes a low cardiac output because oftentimes the heart is preload dependent in CHF. And in addition to that, just a CHF exacerbation, like with reduced ejection fraction, you'll have a low cardiac output. This will tell the kidneys that there's not enough circulating blood. So the kidneys will think that we're hypovolemic, even though in reality, the body is hypervolemic. This will tell the kidneys to turn on the renin-angiotensin-aldosterone system. This will also, in the same way, tell the hypothalamus to release ADH. Because as we talked about earlier, when the blood pressure goes down by 10 to 15, the hypothalamus says, hey, we need to reabsorb more fluid. We need to get that ADH release. So as you see in the picture, the body looks overloaded, but it acts as if it's underloaded. Similar process happens with end-stage liver disease, but in this case, we have portal congestion of fluid, and this leads to a decreased peripheral vascular resistance. The pathophys of that is pretty complicated. That's its own topic, but it can easily be looked up on the internet. But this leads to the same effect of low effective circulating volume to both the kidney and the hypothalamus. Finally, in end-stage kidney disease, we simply just have kidneys that don't function. So you have damaged tubules, which leads to an increased demand on each of the nephrons that are left and are trying so hard to do the work of an entire kidney. This results in is an increased minimum urine osmolality that the kidney is able to produce, simply because it doesn't have as many workers trying to do the same amount of work. So this leads in less free water excretion, and so you're left with, in the end, the same result, hypervolemic hyponatremia. But how do we treat this? This is often a kind of a cat and mouse type of a treatment. It can be pretty tough, but our options are to diurese the patient, optimize their medication to try and improve their actual disease state that's going on. Sometimes there are interventions we can do, such as paracentesis in end-stage liver disease to take off some of the extra fluid, or dialysis in end-stage kidney disease. And then in the end, transplant will, of course, address the underlying cause, but that's more so for the failed organ and less so for the actual hyponatremia. So here's our big hypervolemic hyponatremia. Key points to take away. Hyponatremia is really an issue with water. It's too much water relative to sodium. How do we fix it? We address the cause and we correct that imbalance. So with hypovolemic, you've lost both sodium and water, but more sodium compared to the water. There's all sorts of causes of this. Any sort of body fluid loss can cause this, and the way you treat it is to replace the fluids. Euvolemic hyponatremia, you've gained too much water. There are lots of causes that can trigger this. In the end, SIADH is the one that we commonly come to if we rule out everything else. The way that we treat this is fluid restriction, and sometimes you can supplement sodium in the case of if you're not able to treat the underlying cause. And then hypervolemic hyponatremia, you've gained both sodium and water, but extra water compared to the sodium. We see this in various types of organ failures, and the treatment is to diurese, get that fluid off if you can, prevent the patient from taking in too much extra fluid, and then treat the underlying disease. Finally, here are our sources. If you have any questions or concerns or comments, please feel free to comment below or send us an email. We would love to hear from you. Thank you so much for joining us today on 10 Clinical Minutes. We look forward to seeing you next time.